Poor leg circulation or nerve trouble. 5 differences seniors should know. A cold foot may suggest a circulation problem. Burning toes may suggest irritated nerves, but the symptom that confuses people most is pain that begins while walking, because both reduced blood flow and compressed nerves can cause it. The difference may come down to one small question most people never think to answer. When you stop walking, is standing still enough, or do you have to sit down? That detail can completely change which problem a clinician investigates first. Picture 2 imaginary neighbors, Helen and Ruth, both in their 70s. They take the same route every morning. Helen develops a deep cramp in her left calf near the same mailbox. Ruth develops heaviness, burning, and weakness in her legs at almost the same point. Both call it walking pain. Both assume it is part of getting older. But by the end of this video, 5 differences will make their patterns look nothing alike. There is also one detail Helen has not mentioned yet. It appears at night, and it suggests that the answer may not always be circulation or nerves. Sometimes it can be both. Before we follow their clues, remember this safety rule. Sudden severe leg pain with a pale or unusually cold foot, new numbness or difficulty moving the limb needs emergency care. Sudden swelling, warmth, redness or discoloration, and tenderness in one leg needs prompt medical assessment for a possible clot. If it comes with shortness of breath, chest pain, fainting, or coughing blood, seek emergency help immediately. This video is designed to help you notice and describe a pattern, not diagnose it at home. One more clarification will prevent a common misunderstanding. Poor circulation is not one diagnosis. Arteries deliver blood to the legs. Veins carry blood back toward the heart. Most of the confusion with nerve pain involves reduced arterial flow, especially peripheral artery disease or PAD. Vein problems produce a somewhat different pattern, which will become important in the 4th difference. Now return to Helen and Ruth. The first difference is what starts the symptom. Helen can sit through breakfast without calf pain. She can read for half an hour without it. But when she walks far enough for her calf muscles to work harder, the same deep tightness returns. When leg arteries are narrowed, resting muscles may receive enough blood for their immediate needs. Walking, climbing stairs, or going uphill increases the muscle's demand for oxygen. If blood flow cannot keep up, discomfort may appear in the calf, thigh, hip, or buttock. The classic PAD pattern is not simply "my leg hurts." It is a repeatable relationship between effort and discomfort. A person walks. A working muscle begins to cramp, ache, tighten, burn, or feel unusually tired. The person stops. The symptom settles. Walking resumes, and a similar feeling returns after a similar amount of effort. Helen notices that hills bring the cramp sooner than level ground. Carrying a grocery bag also shortens the distance. That repeatability is an important clue. Ruth's symptoms are less loyal to effort. They sometimes begin when she stands in line, even though her legs are barely moving. On other days, she feels burning or tingling while resting. Walking can make the feeling worse, but muscular effort is not the only trigger. That makes a nerve-related cause more important to consider. Peripheral neuropathy can produce burning, tingling, prickling, stabbing pain, numbness, or sensitivity while a person is sitting or lying down. A compressed nerve in the lower spine can behave differently and become irritated during standing or walking. This is why "it happens when I walk" is only the first sentence of the story. The first useful question is, does the symptom reliably follow muscular effort? Or can it appear while the legs are doing very little? Effort-linked muscle discomfort makes arterial circulation important to check. Burning, tingling, numbness, or electric sensations that also occur at rest make nerves important to check. These are clues, not proof, and the next difference is often more revealing. Helen reaches the mailbox and stops. She remains upright with one hand resting on the fence. Within a few minutes, the calf cramp fades. She does not have to sit, bend, or move her back into a different position. Ruth stops beside her, but the heaviness remains. She walks to a bench and sits. Then she leans forward slightly. The discomfort begins to release. That is the second difference. What must happen before the symptom improves? With PAD-related walking pain, stopping the muscular work is often enough. The person may remain standing because the relief comes from reducing the muscle's demand for blood. With lumbar spinal stenosis, standing upright or walking can narrow the space around nerves in the lower back and worsen pain, burning, numbness, or weakness. Sitting or leaning forward may create more room around those nerves and bring relief. This is sometimes called the shopping cart clue. Someone may struggle while walking upright but travel farther when leaning forward over a cart. The same person may tolerate a stationary bicycle better than an upright walk because the back remains flexed. So do not tell a clinician only that rest helps. Explain what rest means. Did you stop walking but remain standing as Helen did? Did you need to sit or bend forward like Ruth? Did turning, bending, or changing the position of your back alter the sensation? The question is simple. Is stopping enough, or does position matter? For Helen, stopping is enough. That leans toward an arterial pattern. For Ruth, position matters. That leans toward spinal nerve compression. But neither conclusion is final because the sensation itself carries another clue. The third difference is how the symptom speaks. Most people are asked to rate pain from 0 to 10. Severity matters, but the words used to describe the feeling may reveal more than the number. Helen says her calf feels as though the muscle is being squeezed from the inside. It becomes tight, tired, and cramp-like. She points to the muscle, not the knee or ankle joint. PAD commonly produces discomfort in a working muscle. People may describe cramping, aching, fatigue, tightness, heaviness, or sometimes deep burning. Ruth uses a different language. She describes heat, pins and needles, and a brief electric line that sometimes travels from her buttock toward her foot. On bad days, the leg feels weak or less dependable. Nerve symptoms are often described as burning, tingling, prickling, stabbing, shooting, buzzing, electric shocks, numbness, or unusual sensitivity to touch. Peripheral neuropathy can also create the false sensation of wearing a sock when the foot is bare. Some people feel too much. Even the weight of a bedsheet may hurt. Others feel too little and lose the ability to detect pain or temperature normally. That second problem can be especially dangerous because a blister, hot surface, or small injury may go unnoticed. Here is the trap. One word cannot diagnose the cause. PAD can sometimes burn. Reduced arterial flow can eventually be associated with numbness or weakness. Venous problems may include tingling. Nerves can cause aching or cramping. The body does not always respect the vocabulary in a textbook. The useful clue is the combination of feeling and timing. A deep calf cramp that repeatedly appears with walking and settles when the person stops has a different pattern from burning toes that become noticeable in bed. A shooting sensation that follows a line from the buttock down one leg tells a different story from heaviness that builds in both ankles after a day of standing. Choose the closest word for your symptom right now: cramping, burning, tingling, numbness, heaviness, or weakness. Now add when it happens. Cramping while walking is far more useful than leg pain. Burning in both feet at night is far more useful than my feet bother me. If you want, leave just one word in the comments: walking, standing, or night. You may be surprised how many people have been struggling to describe the same pattern. Helen's story now leans toward circulation. Ruth's leans toward a nerve in the lower back. But the fourth difference is something neither woman can describe with her eyes closed. It is what the legs look and feel like from the outside. Helen compares her feet after taking off her shoes. Her left foot sometimes feels cooler than the right. The skin has occasionally looked paler, and a small sore on one toe has taken longer than expected to heal. PAD can cause one foot or lower leg to feel cooler than the other. It may contribute to color changes, slow-growing toenails, reduced hair growth on the lower leg, and sores on the feet or toes that heal slowly or do not heal. Not everyone with PAD has these changes. In fact, many people have few or no obvious symptoms, and a foot can look different for many reasons. This is not an invitation to diagnose yourself by comparing photographs online. Ruth's feet usually look normal even when they burn or tingle. That can happen with nerve trouble. A nerve can send too much, too little, or distorted information while the skin above it appears unchanged. The absence of a visible change does not make the sensation imaginary. But nerve damage can still lead to visible problems later. If sensation is reduced, a person may not feel a blister, pressure spot, or cut. The injury can grow before it is noticed. A wound, therefore, does not prove that circulation is the only issue. Blood flow, sensation, pressure, and infection can all affect healing. Now consider a third outside pattern: swelling around the ankles or lower legs, visible varicose veins, itching, heaviness after standing, or reddish-brown skin changes near the ankles. That pattern can fit chronic venous insufficiency. When leg veins or their valves do not move blood back toward the heart effectively, blood can pool, particularly during long periods of standing. Symptoms may improve when the legs are raised. Think shortage for arteries and pooling for veins. A cooler foot, color change, or slow-healing toe wound raises concern about arterial flow. Swelling and heaviness that build with standing can fit a venous pattern. Burning or numbness with little visible change can fit a nerve pattern. However, a sudden change is different from a gradual pattern. Sudden one-sided swelling, warmth, redness, or discoloration, and pain or tenderness needs prompt medical attention because a deep vein clot is one possible cause. The safest habit is not to perform a circulation trick. It is to check both feet regularly for new color changes, swelling, blisters, pressure spots, cracks, or wounds, especially if you have diabetes or reduced sensation. Use a mirror or ask for help if the soles are difficult to see. At this point, Helen and Ruth seem easy to separate, but the fifth difference makes the pattern clearer, and then Helen's missing nighttime detail changes the story again. The fifth difference is the map. Where does the symptom begin and where does it travel? Helen traces a circle around the thick part of one calf. The discomfort stays deep in that working muscle. It does not begin in her back and shoot downward. It does not start in the toes and gradually climb upward. PAD discomfort often appears in the muscle group whose blood supply cannot meet the demand. The calf is common, but the thigh, hip, buttock, or ankle may be affected depending on where the artery is narrowed. One leg may be worse, although both can be involved. Ruth draws a line instead of a circle. Her sensation sometimes begins around the buttock and travels down part of one leg. That radiating path can fit irritation or compression of a spinal nerve. Back pain may be present, but it does not have to be. Peripheral polyneuropathy creates another map. It commonly begins farthest from the center of the body, often in the toes or feet, and may gradually spread upward. When both feet are affected in a similar pattern, people sometimes describe an invisible stocking of burning, tingling, or numbness. So do not point only to the place that hurts most. Trace the entire route. Is it a deep circle in a working calf? A line from the buttock down one leg? A similar burning or numb area beginning in both feet? Or swelling across an ankle and lower leg? The map may tell a clinician more than the pain score. Now let's reveal the detail Helen left out. Her walking symptom still follows an arterial pattern. One calf, repeatable effort, relief while standing still, and a cooler foot. But at night she sometimes feels burning and tingling in the toes of both feet. The bedsheet can feel irritating. That second pattern does not neatly belong to the calf cramp. It raises the possibility of a separate nerve problem. Helen may not have circulation trouble or nerve trouble. She may need to be evaluated for both. This overlap matters particularly for people with diabetes, because diabetes is associated with both peripheral neuropathy and PAD. Reduced sensation can hide an injury. Reduced blood flow can make healing more difficult. Someone may therefore feel fewer warning signals at the very time the foot needs closer attention. This is why a home checklist cannot deliver the final answer. Pressing a toenail, rubbing the leg, seeing whether socks leave a mark, or trying to feel your own pulse cannot reliably separate arterial, venous, and nerve problems. What can you do that is genuinely useful? If walking is safe for you and a clinician has not told you to restrict activity, observe your normal routine without pushing through severe symptoms. Record what you were doing when the feeling began. Note whether standing still was enough, whether sitting or leaning forward helped, or whether raising the leg changed swelling. Use your own sensory word. Mark the exact location and whether it affects one side or both. Record any temperature difference, color change, swelling, blister, or wound. Note whether the same pattern returns and approximately how long it takes to settle. That is not a home diagnosis. It is a clear history, and a clear history helps a clinician select the right examination. When PAD is suspected, a clinician may check the skin and pulses and use an ankle brachial index, usually called an ABI. This painless test compares blood pressure at the ankle with blood pressure at the arm. Doppler ultrasound or other vascular testing may be used when appropriate. When peripheral neuropathy is suspected, the evaluation may include sensation, strength, balance, coordination, and reflexes. Blood tests may help identify possible causes. In some cases, nerve conduction studies and electromyography assess how nerves and muscles are functioning. Venous symptoms may be evaluated with duplex ultrasound to examine blood flow and check for problems such as a clot or faulty veins. When posture and radiating pain suggest spinal nerve compression, the history, physical examination, and sometimes imaging help guide the next step. You do not need to demand every test. You need to bring the pattern. Ask, could this be arterial, venous, nerve-related, or a combination? Would an ABI, vascular ultrasound, or neurological examination be appropriate? Could diabetes, a medicine, a vitamin deficiency, kidney or thyroid disease, or pressure on a spinal nerve be contributing? And which changes should send me to urgent care? One final safety reminder matters. A non-healing foot wound or recurring leg pain should not be dismissed as normal aging. Sudden severe pain with a pale or cold foot, new numbness, or loss of movement is an emergency. Sudden shortness of breath or chest pain with possible clot symptoms is also an emergency. New leg weakness with loss of bladder or bowel control, or numbness around the groin or seat area requires emergency assessment for severe spinal nerve compression. Now return to your original one-word description. Cramping, burning, tingling, numbness, heaviness, or weakness. Add the sentence that changes everything. When does it begin? What makes it stop? And where does it travel? Helen and Ruth both began with the same complaint. My legs hurt when I walk. By the end, Helen's repeatable calf cramp, relief while standing, and cooler foot raised concern about arterial circulation. Ruth's posture-dependent relief and radiating sensation raised concern about spinal nerves. Helen's nighttime burning in both toes suggested that more than one problem could be present. The body rarely announces a diagnosis with one perfect symptom. It leaves a pattern. Notice that pattern. Protect your feet. Write down changes. Then bring the evidence to a qualified medical professional. If someone you care about keeps saying their legs are just tired, share this video with them. That simple phrase can hide several very different stories. And pain is not the only clue your legs give you. Another warning can appear when you try to rise from an ordinary chair without using your hands. That movement cannot diagnose circulation or nerve damage, but it can reveal how strength, balance, and mobility may already be affecting independence. In the next video, you will learn how to perform the chair rise test safely, which chair can make the result misleading, and what to do if you cannot stand on the first attempt.